So, Dr. Garcia, what are some of the similarities and differences in using the open abdomen technique in adult versus pediatric patients?
Dr. Schwartz, thank you for inviting me. Some of the similarities are, I think, the difficulty in making a decision on when to operate, whether it's from lack of domain, from necrosis of bowel, or for bleeding. I think that the surgeon sometimes struggles with that decision. Is it this time to operate? Can I wait a little longer? Should I wait a little longer? And I think that's similar in the peds patient and the adult patient. I think also similarities is the post-op fluid loss. We all struggle with that. I think that in the pediatric patient, it might be a little more important, but not necessarily. It depends on how sick, how septic the patient is. And then I think the other similarity is also the decision on when to reoperate. When do I reoperate? Do I wait 1 day, 2 days? And that I think is similar in both patient populations. I think the differences in the pediatric patient is that we have the advantage on the smaller patients of being able to use a silo bag. And I think that to me, that's an advantage because not only can I quickly put on a silo bag, I can also quickly remove it and keep an eye on the bowel. And to me, that's a big difference that I don't have the advantage of doing anything quite as easy and similar in my adult patients. And I also think one of the differences that's harder in the pediatric patient is there's a lot less skin to mobilize. And for long-term care of the patient, it makes it a more difficult decision than in an adult patient.
Thank you. I think that you made some very good points about size discrepancy, both of the abdominal cavity as well as getting coverage. Very limited, particularly in neonates, as you well know. So what are some of the lessons pediatric surgeons have learned or innovated that can apply to the adult patient? And vice versa, what lessons and innovation have adult surgeons provided for us in neonatal and pediatric surgery?
I think that the pediatric surgery field, because of the history of dealing with congenital abdominal wall defects, gave us a lot of educational tidbits of how to deal with these open abdomens. The thought of putting a silo bag and serially advancing the closure of that abdomen is something that I think is a basis for a lot of the open abdomens that we do in pediatric surgery. And also one of the things that came from pediatric surgery is a staged repair of these abdominal wall defects. Prosthetic use with anything from synthetic to skin substitutes. And I think it all originated from having to deal with these very large cephaloceles and very large gastroschisis. While in the adult population, the adult trauma surgeons taught us all about open packing for damage control. And that to me has been invaluable. I mean, I'm old enough that we were not doing a lot of open packing. And this sort of, when it came upon, when the adult trauma surgeons introduced it, it became a big changer to deal with many open abdomen situations. And I also think that the adult surgeons taught us about wound vac usage, which is now something that we use every day in pediatric surgery, that came from the adult population.
Dr. Garcia, you mentioned fluid loss through the open abdomen. This is a major problem both in the neonates and pediatric patients, as well as in adults. And the program addresses this, and I'd like you to comment further on what are the best ways to manage this fluid loss? How do you measure it? How do you replace it?
So fluid loss management starts at the very beginning in the operating room when you decide what type of wound closure are you going to use. I mean, sometimes if you have the luxury of being able to place a wound vac, which will allow you to measure the fluid loss, I think it's advantageous. Sometimes you're not giving that luxury and it becomes a problem. And I think that the decision on how are we going to monitor fluid loss has to do with what kind of a temporary wound closure am I going to use. Then once the patient gets back to the ICU is monitoring that fluid loss and how am I going to replace it? Am I going to check albumin, IgG levels? How am I going to know how much the volume? And in replacing it, am I going to replace it with albumin or 3% or crystalloid? it becomes a very a very difficult problem post-op on the patients. And I think that it has to be something that you think about when you're starting the case.
So finally, with this program, what do you believe to be the key takeaways from the session for you? You've had an excellent panel giving excellent presentations. Did anything surprise you that was presented that you were not aware of, or is going to change how you're going to manage patients in the future?
I think that the key takeaways for this whole topic is be aware and comfortable in making the decision of when to open the abdomen. Sometimes it's very easy. It's a congenital anomaly and you have to deal with the open abdomen, but many times it's not. And I think that the struggle of when to make that decision is something that the surgeon has to be very comfortable with. And so my key takeaway was for when to make that decision and how to proceed, when to leave it open. And then also, what are my options on closure? And like you described, there's sometimes you can't use a wound vac. So then what other options, what synthetic mesh, what do I have that I can use to get my abdomen closed?